to welcome and introduce the host and convener for this continuous medical education series under the edges of Mumbai Hematology Group, Dr. M.B. Agarwal. Sir is Professor and Head Department of Hematology, Bombay Hospital Institute of Medical Sciences, Mumbai. He is also associated with various other esteemed institutes like PD Hinduja Hospital, Leela Hospital, Fortis Hospital, and Breach Candy Hospital in Mumbai. He is the president of Mumbai Hematology Group as well. I request Dr. M.B. Agarwal to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit. Good evening to one and all. Today, our guest speaker is Dr. George Castillo from Dana-Farber, Boston. He's going to lecture on BTK inhibitors in Waldenstrom's. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and team from Zydus, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. George Castillo from Dana-Farber, all our discussants who are themselves eminent hematologists or medical oncologists, and you participants from almost 27 countries this evening for sparing your time and joining us. This is the website of Mumbai Hematology Group, www.mhgindia.com. All our future academic activities can be seen there and you can register for them as well. Registration is free. Tomorrow morning, we had a webinar by Professor Fallini from Italy on T-cell lymphomas. Unfortunately, he is not well. So this has been cancelled for the moment and rescheduled on 19th of March. So there will be no webinar tomorrow morning. Our discussants are very important persons from India. Dr. Ganju from Nagpur, Dr. Khandelwal from Delhi, Dr. Arun from Chandigarh, Dr. Avinash Kumar Singh from Patna, Dr. Radhika from Hyderabad, Dr. Kartika from Salem, Dr. Dakate from Nagpur, Dr. Nitin Gupta from New Delhi, Dr. Nutan Joshi from Vellore, Dr. Priyanka Soni from Jaipur, Dr. Ranjit Matthew Varghese from New Delhi, Dr. Urmimala Bhattacharjee from Chandigarh, Dr. Vishnu Sharma from Jaipur, and Dr. Vishwadeep Khushbu from Nagpur. It's a pleasure to introduce our speaker. Once again, he has obliged us by being with us. He has taken a number of webinars for us during this pandemic and after the pandemic got over. Dr. George Castillo. He's clinical director, Bing Center for Waldenstrom Macroglobulinemia, Division of Hematological Malignancies, Dana-Farber Cancer Institute. He's associate professor, Harvard Medical School, Boston. He was born in Peru, received his medical degree in Mexico, and completed his internal medicine and hematology and oncology training at the University of Massachusetts and Brown University. The Waldenstrom Macroglobulinemia Clinic has seen over 4,000 patients of Waldenstrom during the last decade. He is the principal investigator in a series of innovative clinical trials evaluating non-chemotherapeutic approaches for patients with Waldenstrom. He is a member of the NCCN Committee for Myeloma, Amyloidosis, and Waldenstrom. He has authored over 275 peer-reviewed articles and has published his research in NEJM, JCO, Lancet Oncology, and Blood. I request him to lecture on BTK inhibitors in Waldenstrom macroglobulinemia. Over to you, sir.
All right, thank you very much, Dr. Agarwal, for the kind but lengthy introduction. So today I am going to be talking about BTK inhibitors in the management of Waldenstrom's macroglobulinemia. I'm going to share my screen. I hope you all can see my application currently.
Yes.
Over the next 40 minutes or so, we'll talk about the data that supports the use of these agents in patients with Waldenstrom's. As I do with all my presentations, my email address is right there on the screen, jorgej_castillo@dfci.harvard.edu. If you like the slides, if you like a specific graphic, if you have any more questions, you have any case that you find challenging, please do not hesitate on sending me an email, and I'll be happy to be of help. Good. So to start, I'm going to provide you with my disclosures. I'm going to just leave there for a few seconds before moving forward. Good. So, I mean, I always like to start with making a proper diagnosis of Waldenstrom's. I think this has evolved over the last decade. I think most of us have, access to getting an IgM monoclonal protein identified in a protein electrophoresis and immunofixation. And most of the times that is the initial, finding that makes us suspect that a patient might be having Waldenstrom's macroglobulinemia. Having said all that, the presence of an IgM monoclonal protein alone is not diagnostic of Waldenstrom's. We do have other conditions such as IgM-MGUS. Other lymphomas can secrete IgM, such as marginal zone lymphoma, CLL, and follicular lymphoma, mantle cell lymphoma, for example. It's very rare, but it does exist. And there is a rare subtype of myeloma called IgM myeloma. So IgM alone is not Waldenstrom's. Having said that, it's probably the most common malignancy associated with IgM secretion currently. Once an IgM, monoclonal IgM is detected, the next step is to go into the bone marrow and see if there's an excess of lymphoplasmacytic cells or other abnormal cells in there. And if this were an IgM-MGUS, the bone marrow will show no disease or very little disease. IgM myeloma, we can see an excess of plasma cells in there. But what is diagnostic of Waldenstrom's is the presence of these lymphoplasmacytic cells, which are an intermediate form between a mature B cell and a mature plasma cell. And these are the cells that normally produce IgM. Now, we all have these lymphoplasmacytic cells. We all should have a small, less than 1% of these cells in our marrows. So anything over 1% is abnormal. So if we follow the international criteria for the diagnosis of Waldenstrom's, any lymphoplasmacytic infiltrate in the marrow is enough to make a call for a diagnosis of Waldenstrom's from a pathological perspective. Now, if we follow the Mayo criteria, the Mayo criteria uses a 10% or higher infiltration to call a Waldenstrom's macroglobulinemia. So at the Dana-Farber, we tend to use the international workshop criteria. So for us, any infiltrate is enough to diagnose Waldenstrom's. Now, if we just look at lymphoplasmacytic lymphoma, just at the lymphocytic appearance of the cells, that alone is not diagnostic of Waldenstrom's either, because we can have, marginal zone lymphoma with plasmacytic differentiation. We can have IgM myeloma actually has some lymphoplasmacytic features as well, even with CD20 expression, which is very rare in myeloma, but more common in IgM myeloma. So again, alone, this feature is not totally diagnostic. We do have a group of lymphoplasmacytic cell patients who have, IgG, IgA, or even free light chain, or even no secretory. These are non-IgM lymphoplasmacytic lymphomas, and therefore they are not Waldenstrom's, even though they should be managed as Waldenstrom's, but they are formally diagnosed as Waldenstrom's. So again, alone, a lymphoplasmacytic lymphoma in the marrow is not diagnostic of Waldenstrom's either. With those two factors, the IgM and the lymphoplasmacytic lymphoma, I think you already have a strong suspicion that somebody or a patient that is in front of you can have Waldenstrom's. But what we tend to do is to confirm this diagnosis further, or when we don't have a very valid clinical pathological picture and it's a little confusing, we can proceed with the third step here, which is the identification of the MYD88L265P mutation. This is a mutation that was detected in diffuse large B-cell lymphoma initially, and then over 90% of patients with Waldenstrom's have been found to have these mutations in multiple studies that we will see in a minute. And this can be detected nowadays following different techniques, specifically PCR, which is still the preferred method in the bone marrow in terms of sensitivity. There's platforms now of next-generation sequencing. That sensitivity of these tests is a little bit less. And obviously, when we think about just blood, any of these tests have much less sensitivity. So still, bone marrow is the best tissue to get this testing on, and PCR is preferred over NGS in terms of sensitivity. Again, MYD88 alone is not diagnostic of Waldenstrom's either, because patients with IgM-MGUS can have MYD88 mutations up to 50 to 60% of the times, and also patients with CLL in marginal zone lymphoma can have these mutations up to 5 to 10% of the times. So again, none of these three factors in the screen are diagnostic of Waldenstrom's alone. But if we put the three of them and I think it's an important message. The second important message here is that we don't have to treat everybody at the time of diagnosis. If a patient is asymptomatic, I think the best approach still is not to treat. And I think the list on the left actually gives us the idea. When we treat patients with Waldenstrom's, with cancers in general terms, we want to cure them, we want to prolong their survival. But actually, as of today, there's no data to suggest that we can cure Waldenstrom's, not even with allogeneic transplants. I'm actually treating a lot of patients who had allogeneic transplants 10, 15, 20 years ago, and they're relapsing. So I cannot tell you categorically we can cure Waldenstrom's with allotransplants. And at this time, there's no data that any intervention prolongs survival, right? In fact, actually, there was a study from the Mayo Clinic that just came out this year, 2022, in which if you had a patient with Waldenstrom's asymptomatic, untreated, these patients have a normal life expectancy compared to other individuals of the same age, sex, and race in the United States without Waldenstrom's. So these patients have a normal life expectancy, the disease is incurable, and many reasons not to treat. Now, our treatments are great, and we'll see that in a minute, very effective, but they do have some toxicities and leukemias and arrhythmias and other problems, neuropathy, and they promote resistance too. So the list keeps getting bigger in why not to treat patients who are otherwise asymptomatic. Here on the right, this is data from a study that we published a few years ago. This is a collection of patients with asymptomatic or minimally symptomatic or smoldering or inactive Waldenstrom's. There are many ways in which we call this condition. So these patients have formally the diagnosis of Waldenstrom's, but they don't have any symptom of Waldenstrom's, so the symptoms are not severe to affect the patient's activities of daily living. So when we follow these 439 patients over time, we can see that about 2 years, about 30% of patients need to be treated. So that's about a 15% per year. But then that curve kind of flattens out. And over the next 8 years, it goes from about 30% to about 80%. So about 7% per year. So when we get to the 10-year mark, about 80% of patients who were asymptomatic at diagnosis will need to be treated. But again, there's a 20%, 1 in 5 patients who will not need treatment for longer than 10 years from diagnosis. So I think it's an important exercise, to let our patients, let us know, if they're going to be one of these patients who might not need treatment for a number of years. We actually developed a patient risk calculator. This is specifically for patients who are asymptomatic at diagnosis, untreated. You can access this on a website. It's called awmrisk.com. And based on that, we have 4 different values that we input. We have a bone marrow infiltration. In this case, I put an exercise of 40%. IgM protein, I put an exercise of 3,500 milligrams per deciliter. Beta-2 microglobulin, 2.5 milligrams in this example, and an albumin level of 4 grams per deciliter in this example. So basically, you enter all these values. The interesting part, at least something to have in mind, is that these 4 values should be taken around the same time. So bottom line, you shouldn't be using the bone marrow infiltration from 2015 and the IgM level from 2022. I mean, that's not what this exercise is all about. So all the values around the same time, and at that moment, you can make that estimate. So you click calculate risk score right here on the bottom once you enter the 4 values, and on the right, you will have the results. In this case, with these values, we have a patient with a medium risk category. And what that means is the estimated median time to treatment would be about 4.8 years. So on the right, in that paper, we also put the progression time for the different categories. So if somebody had a low risk, the median time to treatment is about 9 years. For the intermediate is 4.8 years, as we saw before. And for the high risk, the median time is about 2 years, 1.8 years. So these can help us understand, number 1, how worried we need to be for our patients. Number 2, maybe how frequently we need to follow an asymptomatic patient. So the NCCN has adopted these criteria, and they are recommending if somebody has a low-risk disease, these patients could be seen every 6 to 12 months. If patient has an intermediate risk, Patients can be seen between 4 and 6 months. If a patient has a high risk, a patient can be seen every 2 to 3 months in follow-up. This does not imply that patients need to be treated. This implies that patient might need treatment sooner, and then we might need to monitor these patients a little more frequently. We identified a group of patients who are ultra high risk, in whom the time to treat within 2 years is 80%. So that begs maybe a clinical trial for those patients in terms of recommending treatment, even though the patients are asymptomatic. But at this time, asymptomatic patients should be monitored without intervention. Now, the manifestations of Waldenstrom's, once the patients become symptomatic, are very diverse. And still the most common reason to treat patients with Waldenstrom's are patients with symptoms of anemia and constitutional symptoms, fatigue, shortness of breath, fevers, night sweats, and unintentional weight loss. But other classic manifestations of Waldenstrom's include hyperviscosity syndrome, patients present with nosebleeds and headaches and blurred visions because of retinal vessel changes, typically seen in patients with IgMs over 3,000 and much more so patients with IgMs over 6,000. IgM neuropathy is also a classic manifestation of Waldenstrom's. Bilateral, symmetrical, sensory, affects the feet before it affects the hands. Anti-MAG antibodies could be positive. And if we do nerve conduction studies, we will see a clear demyelinating pattern. Axonal patterns are less common. Small fiber neuropathy is much less common. Other classic manifestations are cryoglobulins and cold agglutinins. This has to do with the sensitivity of the IgM protein to cold. And if you have cryoglobulins, you have essentially a vascular occlusion. If you have cold agglutinins, and you have red cell destruction, and patients manifest in those ways too. Light chain amyloidosis can complicate Waldenstrom's. This is about 5% of the times. We have to think about AL amyloidosis when we have a patient with restrictive cardiomyopathy or nephrotic syndrome, or a coagulopathy that is less understood, or just simply not feeling well and deteriorating. So very clear, something that we need to understand a little bit better. And for that, abdominal fat pad biopsies, free light chains, urine tests, and things like that. On the left, we have the extramedullary disease. Extramedullary disease is very rare at presentation, but as the patients progress over time, after multiple treatments, patients tend to have more of this. Classically, we have lymphadenopathy and hepatosplenomegaly, but we have other rare extramedullary conditions that I could see here. Renal involvement, which is classic in myeloma, is very rare in Waldenstrom's, 2 to 3%. Lytic lesions that are very classic in myeloma, they are very rare in Waldenstrom's, you can see about 1 to 2% of the times. Pleural effusions, and the meningitis because of Waldenstrom's called Bing-Neill syndrome. So again, as you can see, clinically speaking, Waldenstrom's is a very diverse condition. And I think that's what keeps things interesting for me. You know, as I see, 16 patients with Waldenstrom's in one day, I can see 16 different clinical pictures, and that keeps things interesting, clinically speaking. Now, when we get to treat our patients, right, as we've seen, the majority of our patients will need treatment at some point. We do have a number of treatment options that are extremely effective. And these are rituximab combination regimens. I just wanted to put this table in here. These are all endorsed by the NCCN guidelines. Cyclophosphamide, fludarabine, bendamustine are the chemotherapeutic agents. Great response rates, overall response rates into the 80s, 90s, major response rates in 70s and 80s, and progression-free survivals in 5-6 years. Similar data with proteasome inhibitors, bortezomib, carfilzomib, and ixazomib. Overall response rate between 80 and 90%, major response rate between 60 and 70%, and progression-free survivals also measuring about 4 or 5 years too. Now, for a while there, we were using maintenance a lot because of the follicular lymphoma data, but the MAINTAIN study, which was presented at ASH in 2019 and updated recently at the workshop in Madrid in 2022, we can see here that really after attaining a partial response to bendamustine and rituximab, maintenance rituximab does not offer a benefit in terms of progression-free survival or overall survival. Now, there was a small subgroup analysis showing that patients older than 65 maybe benefited from maintenance. Again, we're still waiting for the final manuscript to be reported. This has not been published fully just yet, but based on this, we are recommending much less maintenance rituximab nowadays, especially if a patient obtains a deep response from bendamustine and rituximab. If a patient doesn't have a deep response, meaning a minor response, maybe these patients benefit from maintenance. Or if a patient has an organ damage like a kidney or other problems, and we want to induce a deeper response, guarantee the deeper response, sometimes we can use maintenance in those scenarios. So I still use maintenance in very selected groups of patients. Now, how do we move forward, or at least in a different direction from rituximab-containing regimens? And I think this is where understanding the biology of the disease is very important. The discovery of the MYD88 mutation, it was an important discovery made by my mentor, Stephen Trion. This was published in 2012 initially. It's almost more than 10 years now. It's still good. It's still good in new news, but still getting some time now, more than 10 years. And again, these data have been validated in multiple settings. We have an Indian study here. We have a study from multiple studies from Europe and other studies from Asia. On the United States, even we have a couple of Latin American studies here on the bottom. And the message is the same. The prevalence of MYD88 mutations in Waldenstrom's is very high, and it could be anywhere between 80 and 100%, depending on which technique you use. Obviously, we still believe that PCRs tend to be a better, more sensitive testing than next-generation sequencing, specifically when you have low-burden disease. CXR4 mutations is another group of mutations that were found in patients with Waldenstrom's. They are all in the carboxyl terminal, as you can see here. And the difference between these mutations and MYD88 is that, as you can see here in the back, MYD88 is typically a one-spot, mutation in 265. Here in CXCR4, we have multiple mutations in different spots. Now, we do have a couple of hotspots here in 334 and 338. These are, bolded. These are where we see most of the mutations. But still, there are at least other 30 different spots where CXR mutations can be identified. And again, initially, we reported in whole genome sequencing 27%. We developed PCR probes, and that went up to about 40%. And multiple studies, again, from Europe, Asia, and the United States show a high prevalence of these mutations. Now, these mutations are somatic mutations. There's a group of children who are born with congenital mutations in CXCR4, and they have a condition called WHIM, it's an immunodeficiency. These are somatic mutations. And not only that, they are subclonal to MYD88, and we know that. Interestingly enough, we were thinking that maybe if somebody is not a CXCR4 at the moment of diagnosis, and as we treat them, maybe CXCR4 is going to come up, as a process of resistance or under pressure from the treatments. But that has not been the case. The proportion of CXCR4 mutations in the frontline setting, the relapse setting, and the multiple relapse settings actually was very similar, which is a little bit different what we see, for example, with TP53, in which there is a higher proportion of TP53 clones developing after exposure to therapies. With CXCR4 mutation, doesn't seem to be the case. Actually, in patients with MGUS, not only we see a lot of MYD88 mutations, but also we see a lot of CXCR4 mutations, which means to me that MYD88 or CXCR4 are very early mutations occurring in patients with Waldenstrom's, even before they are Waldenstrom's. And again, more research is needed to understand the process from developing these mutations and actually developing Waldenstrom's. I think there's another step in the middle, another genomic change that is prompting the malignant transformation of these patients. Now, this is a schema of how we understand the interaction between MYD88 and CXCR4 in patients with Waldenstrom's. MYD88 is a transmembrane protein, as well as CXCR4 is. And when MYD88 gets activated because of the mutation, it actually homodimerizes, activates the mitosome here on the bottom. And the mitosome is composed by IRAK1/4, TRAF, TAG1, TRAP, but also BTK. BTK is actually a very important member of the mitosome to continue the activation downstream. So we did studies in which, by blocking BTK, we actually block the entire pathway that ends up in nuclear factor kappa B activation. Now, this is what happens in patients with MYD88 mutations. In patients with CXCR4 mutations, CXCR4 is supposed to bind to CXCL12 and then get internalized, and then obviously the signaling disappears, but the mutation doesn't allow the internalization of CXCR4. So CXCL12 binds CXCR4, CXCR4 is mutated, signals, and it doesn't get deactivated. But this activation pathway is actually through PI3 kinase, AKT, and ERK. So it's just not the same pathway than MYD88. And at the end is when you have nuclear factor kappa B activation. So they kind of meet at the end a little bit. And this is what we saw in the laboratory when we blocked BTK, CXCR4 and AKT and ERK activation still was very high. So we kind of suspected that patients with Waldenstrom's, depending on which mutation they had, they want to respond differently to BTK based on the understanding of the biology. And we will review the clinical impact of these mutations in a minute. Now, importantly, all these treatments that I just mentioned are here. These are the national guidelines in the United States. We call it NCCN. I'm a member of that, as Dr. Agarwal mentioned earlier. So for primary therapy, we have rituximab-containing regimens all over the place, as well as for previously treated Waldenstroms as well. But what I'm putting here on the red boxes are essentially the BTK inhibitors. So the BTK inhibitors, such as ibrutinib, acalabrutinib, and zanubrutinib, they're the current covalent BTK inhibitors available in the market. Not only they are preferred regimens for primary therapy as well as relapse therapy, but also they're category 1, which means that these are supported by prospective and randomized clinical trials, which is not exactly the same for these other regimens, like bendamustine, bortezomib, and cyclophosphamide are also preferred regimens because of the efficacy and the toxicity, but really randomized studies comparing these agents have not been done, or they are still in process and have not been reported. So this is an important message. Currently, BTK inhibitors in the United States for Waldenstroms are preferred regimens and category 1 for all lines of treatment. We'll review the data in a second. So I just put this table. This is a limited table. We do have some ibrutinib, acalabrutinib, and zanubrutinib studies. There are 2 additional covalent BTK inhibitors, tirabrutinib and orelabrutinib. I haven't put this data here because they're not approved in the United States, but they are in use in China and Japan, respectively. This is where these agents are coming from. And that, just to give you an idea, the efficacy of these regimens, so you can compare with the table that I put before with rituximab-containing regimens. So the response rates to any of these treatments are between 90 and 100%. The major responses between 70 and 80%, and progression-free survivals now also measured in several years. So these numbers are very comparable to the numbers in terms of efficacy when we talk about rituximab-containing regimens. As I said previously, unfortunately, we don't have head-to-head comparisons. So based on that, it's very difficult for us to say which treatment is actually better than another treatment. But most of them are monotherapy, with the exception of ibrutinib rituximab. Most of these are monotherapy agents. So what I think we can categorically say is, as monotherapy, BTK inhibitors are probably one of the most effective agents for patients with Waldenstrom's. Let's look at the data a bit closer. So this is ibrutinib monotherapy for previously treated patients. This is the seminal study that was published in New England Journal in 2015, and the long-term data was published in JCO just a couple of years ago. Obviously, this is an FDA-approved medication, the first medication ever approved for Waldenstrom's by the FDA. In this study, not only we saw that was very effective, but we also, as we predicted, based on the preclinical data, we saw that the mutation profile affected the efficacy of these treatments. So when we looked at the MYD88 only, right, patients who had only MYD88 BTK-driven without CXCR4, the responses were very impressive. 100% response rate. All of them had major responses, which is a 50% decrease on their IgMs, and almost half of these patients got into very good partial responses within 5 years of therapy. The patients with CXCR4 mutations, the ones that provided an additional accessory activation pathway, the responses were also good, but not as good. 86% overall response rates, 68% major response rates, and 9% of very good partial response rates. Now, there's a small group of patients without MYD88 or CXCR4. These are patients that, histologically speaking, look like Waldenstrom's, and they do not meet criteria for any other malignancy, and therefore they were labeled Waldenstrom's. We could see some response rates, but all of them were superficial. And not only that, the progression-free survival also mimics the same experience. Patients with MYD88-only disease at 5 years had a 75% progression-free survival rate, compared to about 50% at 4 years for patients with CXCR4 mutations, and a 50% at 2 years for patients without MYD88 or CXCR4 mutations. So I think we can categorically say that the genomic profile affects or impacts the outcomes of patients with Waldenstrom's treated with single agent ibrutinib. We did an additional study in patients in the frontline setting. We put about 30 patients. This was initially published in JCO in 2018, and the long-term data was just published last year in leukemia. About 30 patients experienced. We see a major response rate of 87% with an overall response rate of 100%. and VGPR of 30% about 4 years into therapy. Again, patients with MYD88 mutations had a 44% VGPR compared to about 14% in patients without CXCR4, with CXCR4 mutations. So again, patients with CXCR4 mutations had a lower progression-free survival rate at 4 years, about 60%, versus 90% progression-free survival if you did not have a CXCR4 mutation. So again, we see a very similar impact of CXCR4 in outcomes of patients taking ibrutinib monotherapy. Now, when we looked at ibrutinib and rituximab, this combination also got approval by the FDA in 2018 when the initial study was published in New England Journal. This is the long-term data published in JCO just last year. We can see how, regardless of the genomic profile, the combination of ibrutinib and rituximab showed higher response rates, regardless of the MYD88 mutate or CXCR4 mutational status, than the rituximab and placebo, which was the comparator at the time. Now, but however, we can see the depth of response being affected by the mutational profile. The MYD88 CXCR4 group had a 23% VGPR versus a 44% VGPR or better in patients with MYD88 only disease. The progression-free survival benefited the combination of ibrutinib and rituximab clearly over rituximab alone, in which the median response rate was about 20 months. Having said that, what this study does not tell me is really how beneficial is rituximab in addition, to being added to ibrutinib. Here we have a rituximab arm and an ibrutinib rituximab arm. So ibrutinib makes rituximab better, but we do not know really if rituximab makes ibrutinib better. We don't have an ibrutinib alone arm, which I think is one of the major downsides of this INNOVATE study. When we separate, based on the genomic profile, the progression-free survival of the red curve here on top, and the green curve, they kind of separate a little bit, not as much. The one on top is the MYD88 only. The green on the bottom is the MYD88 and CXCR4 mutations. So just a little bit of a separation, but obviously because of the numbers, it's not statistically significant. Acalabrutinib is another novel BTK inhibitor, covalent, has a stronger binding to BTK and sustains the BTK inhibition levels at a higher rate than ibrutinib does. Very effective. This is data published by Dr. Owen in 2020, with response rates over 90%, major response over 80%. And the progression-free survival was updated at the EHA meeting just last year, with a median progression-free survival for relapse patients at about 68 months and a not reached for previously untreated patients. So highly effective regimens. This is taken twice a day compared to ibrutinib is taken once a day. This is twice a day. The rates of AFib and bleeding, maybe a bit less, a bit more headaches, but again, very effective regimen. This is not FDA approved, and is NCCN recommended only for the relapse setting, mainly because this was not a randomized study, and most of the patients were in the relapse setting. As you can see, 92 patients in the relapse setting compares 14 patients in the treatment-naive setting. The other second-generation BTK inhibitor is zanubrutinib. The zanubrutinib group actually did a randomized phase 3 study. This is the ASPEN study that was published in Blood in 2020. 102 patients were randomized to zanubrutinib, 99 patients were randomized to ibrutinib. And based on this, the idea of the study was to show superiority of zanubrutinib over ibrutinib based on VGPR rate. In this case, we have a 28% for zanubrutinib, 19% for ibrutinib at the time of this publication. And that difference of 9% was not statistically significant. And for that reason, the study was a negative study. They did not meet its endpoint. And as you can see here, at the time of publication in 2020, the progression-free survivals were pretty much overlapping between the two. Where there was a difference was in the side effect profile, and the rate of AFib much lower with zanubrutinib at about 2 or 3% at 18 months, compared to about 10 to 15% of ibrutinib at 18 months. We did see, however, more neutropenia, about 30% at 18 months with zanubrutinib versus about 15% with ibrutinib. So based on this profile with much lower cardiac events, the FDA approves zanubrutinib for the use of patients with Waldenstrom's in November of 2021. So it's about a year and some that this medication has been approved in the United States. It was approved in Canada previously, and since then has been approved in multiple parts of the world, including Latin America, Asia, and Europe as well. The long-term data for ASPEN was presented at ASCO in 2022 by Dr. Konstantin Tam in Australia. And as we can see here, with a follow-up of about 44 months, the VGPR rate has increased in both groups. Now zanubrutinib is about 36%, and ibrutinib is about 25%. This difference now is a little bit more substantial. The progression-free survival also looks a bit different, favoring zanubrutinib over ibrutinib, just barely, not statistically significant just yet, but there was a bit of a difference right there. In the toxicity, at the end, over 3 years of follow-up, we do have lower rates of AFib, lower rates of hypertension, lower rates of bleeding, and lower rates of infection with zanubrutinib. I want to make very clear that zanubrutinib has side effects, and we can see AFib, hypertension, and bleeding and infection with these agents, but we do see it at lower rates than ibrutinib does. And neutropenia kind of levels off and kind of evens out between the two approaches, beyond 3 years of therapy. These updated data should be coming up in a manuscript shortly. This was also updated at the Waldenstrom workshop this past October in 2022 in Madrid. Interestingly enough, looking at CXCR4 mutations specifically, we can see how zanubrutinib tends to have a higher rate of VGPR, about 21%, versus ibrutinib, about 10%. So there's a difference when we think about CXCR4 in patients treated with zanubrutinib, but overall, it seems to have better outcomes than ibrutinib does. And when we look at the progression-free survival, there seems to be a little bit more difference as well. And again, because of the numbers, this might not be statistically significant, but we do see separation in the progression-free survivals, specifically for patients with CXCR4 mutations. I presented at ASH data on the combination of ibrutinib and venetoclax in previously untreated patients with Waldenstrom's. We wanted to provide an all-oral, non-chemotherapeutic approach of finite duration. As we know, patients who are taking ibrutinib, acalabrutinib, or zanubrutinib, they need to be on treatment indefinitely, and that implies years of taking medications, and that obviously implies also cumulative cost as well as cumulative adverse events. So we designed the study in which patients got ibrutinib for a month or for one cycle, and then ibrutinib venetoclax in the ramp up from 100 to 200 to 400 maximum, and then between cycle 3 and 24 full doses, and at 2 years we will stop the treatment. Treatment will have been stopped. Stable disease or response, continue therapy, progressive disease on unacceptable toxicity, stop therapy, and after stopping therapy, either or, we will follow up patients for 4 years to see what the durability of these responses is going to be off therapy. So we enroll about 45 patients, and the features of these patients were very compatible with prior experiences in Waldenstrom's. The median age of therapy initiation is 67, most men, IgM about 4,300. Most patients were anemic with a hemoglobin of a median of 10.2, a median bone marrow involvement of 60%. Half of the patients had lymphadenopathy, 30% of patients had splenomegaly, defined as we see here. 20% of patients had acquired von Willebrand's disease because of high IgMs, some cryoglobulins, and about 38% of patients had CXCR4 mutations. So the response to therapy was 100%, which was great, and the major response rate was 93%. The VGPR was 40%, and actually that met its endpoints. This study met its endpoints. And when we look at the CXCR4 mutations, there was a little bit of a difference too in VGPR, about 50% on patients without CXCR4 mutations and about 24% in patients with CXCR4 mutations. There was a difference. This difference was not statistically significant, maybe because of the sample size, but we did see an impact on the depth of response, despite the addition of venetoclax to ibrutinib. At 12 months, which was the median follow-up, the progression-free survival rates were 92% and about 95% the overall survival rates. Now, in terms of safety, we didn't see major issues here, except for 2 deaths because of ventricular arrhythmias in these patients. We were planning to accrue 50 patients. We ended up accruing 45 patients because we had 2 grade 5 ventricular arrhythmias, which we felt it was higher than expected. And at that moment, we had to stop therapy. So all patients are off therapy as of the end of March of 2022. They're all being monitored, so the study continues, but just in the follow-up phase. And we are collecting data to see how durable the response of therapy is going to be. But again, besides the ventricular arrhythmias, which was unexpected, other side effects were as expected, with a bit of AFib and some GI symptoms, some neutropenias, and just a couple of laboratory tumor lysis syndrome. So really, treatment is highly effective. And besides these ventricular arrhythmias, we didn't see other unexpected problems. Now, what are the reasons for the excess ventricular arrhythmias? That's a little unclear to us at the time. We don't have any autopsy data. We don't have any laboratory measurements to see drug levels, to see if maybe there were higher drug levels than expected. We think that may be something related to the Waldenstrom's itself, but also it could be also the patients too. I mean, the patients who had these events were all men, older than 65. They have multiple cardiac risk factors, including diabetes, hypertension, prior history of arrhythmias, prior coronary artery disease. So at this time, it's a little less clear. This is not something that we have seen with this combination. Previously in mantle cell lymphoma and CLL, we have not seen a signal of a higher rate of ventricular arrhythmias. So, we still need to understand this a little bit better. But the combination seems to be effective. So I think the concurrent BTK and BCL2 inhibition should continue being investigated, maybe with safer drugs than the combination that we chose initially. As many of us here know, there is emergence of resistance to covalent BTK inhibitors, mainly driven by mutations in BTK 481, and there are other mutations that are being reported currently. So it's interesting to see what new agents might be coming up. And one of them is pirtobrutinib, which is a non-covalent BTK inhibitor, which means that it does not need to interact with 481 to exert its BTK blockade properties. This is the initial paper by Anthony Matto. I want to bring your attention to the Waldenstrom's group here next to last on the right. And we can see that most patients, most of the bars go down, which means the disease improves on therapy. And I want to bring your attention to the dark turquoise bars. Most of them are going down. These are patients who were actually progressing on a covalent BTK inhibitor and then responded to the non-covalent BTK inhibitor. And you can see that similar outcomes with CLL, mantle cell lymphoma, and other lymphomas as well. So very encouraging data with pirtobrutinib. Now at ASH, my colleague, Dr. Leah Palombra from Sloan Kettering, presented the data specifically in patients with Waldenstrom's. There were about 80 patients data. 63 of these patients were previously exposed to a covalent BTK inhibitor. And we can see here a major response rate of 67% and a VGPR rate of at least 24%. And as you can see here, most of these patients benefited from therapy. The dark blue bars are the patients who were progressing on the covalent BTK inhibitor. So we can see that there are some people who will not respond, but the majority of these patients actually do respond to these treatments. Obviously, the patients who were stopped covalent BTK inhibitors because of toxicity had better outcomes, and patients who were naive to covalent BTK inhibitors also had better outcomes. Those are easier patients to treat. But again, it's very encouraging to see that even in patients who are progressing on covalent BTK inhibitors, we see a good response to these non-covalent BTK inhibitors, and more data is necessary to understand this a little bit better. The progression-free survival is not as long as we were hoping to see. And again, at about a year into therapy, about 70% of patients had not progressed yet, but it approached about 57%, about 18 months. Having said that, at this time, the sample size is actually very small. So I think it's very possible that this curve is going to be a little higher than what it is currently with more follow-up, but we will see that just a little bit later. And the overall survival at 12 months is about 87%. So encouraging data from non-covalent BTK inhibitors currently. There's another non-covalent BTK inhibitor, is MK1026, which is a nemtabrutinib. This data was presented at ASH of 2021. Just very few patients with Waldenstrom's being treated, not a lot of follow-up yet. There was no updates this year on this drug, but induced an initial response rate, 58%, through a variety of B-cell lymphomas that were otherwise progressing on covalent BTK inhibitor. So encouraging data from this group of treatments coming up, I think, in 2023. Now, there's a list of the selected clinical trials with BTK inhibitors, specifically in Waldenstrom's, and I think I was very surprised to see there were so many studies looking at BTK inhibitors in Waldenstrom's. These are specific for Waldenstrom's. We have combinations, ibrutinib, bortezomib, carfilzomib, and ixazomib, so combining BTK inhibitors with proteasome inhibitors. We do have a study by the Mayo Clinic combining ibrutinib and daratumumab. And we have, I think, a very important study in Germany combining ibrutinib, rituximab, and comparing against DRC. So it's going to be the first study comparing a BTK inhibitor containing regimen versus a chemoimmunotherapy regimen in a randomized fashion. I think the Canadians are doing a very interesting study combining acalabrutinib and bendamustine and rituximab. So 1 year of acala and then 6 cycles of benda-R, all concurrent. So that provides a triplet, a combination of chemo and BTK inhibitor, finite duration therapy. This data was presented at ASH as a poster. Out of 11 patients treated, 10 patients got into a VGPR. So that's like a 90% VGPR rate. So we're very excited about a study of this nature. And as I said before, pirtobrutinib and nemtabrutinib, looking at the non-covalent BTK inhibitors. I actually hashed down this study because it has been deactivated. We were very excited about the ibrutinib, venetoclax, and rituximab versus ibrutinib, rituximab. This was a study by the SWOG group, but based on the ventricular arrhythmias that we reported in our study, this study has been put on hold, and I think will be deactivated at some point. So we just got approval by Loxo of running a random prospective study combining pirtobrutinib and venetoclax, and we're not basically going to do a very similar design of what we did with ibrutinib and venetoclax. It's going to be a 2-year study, finite duration therapy. This is in the relapse setting. Pirtobrutinib being a safer study with much less cardiac toxicity. So we're about to start this study, hopefully in the second quarter of 2023. So just to finalize and conclude, I think BTK inhibitors are probably one of the most effective agents in the management of patients with Waldenstrom's. They do have their problems, and I think it's important that to understand that they carry a specific group of side effects that we need to get familiar with, which include cardiac toxicities, bleeding problems, hypertension, a bit of the risk of infections, cost, the duration of these treatments, which can be very prolonged, but nonetheless, agents that we can use and exploit and maybe investigate better to define, better treatment options for patients with Waldenstrom's. And with that, I want to thank you for your attention.
Thank you so much, Dr. George, for updating us on this aspect of Waldenstrom. Very new data, really very useful. We'll have now the questions from the colleagues here. Dr. Urmi Mala.
Hello, sir. Can you hear me?
Yes, I can hear you well.
Yeah, sir, the most common BTK inhibitor that is available in our country is currently ibrutinib, and we commonly come across the dose intolerance, and most of our patients need dose reduction. So what is your experience regarding this problem, and specifically means long-term response in these patients who go for a dose reduction?
Yes, that's excellent. So if you allow me, we just published a paper on this. So that's perfect timing. So my colleague, Dr. Shayna Saroshek, she collected data from about 400 patients with Waldenstrom's, and specifically looking at our experience with dose reductions. So I am going to share my screen. This is the study. It just came out, accepted December 28th of 2022. So, and this is dose reductions in patients with Waldenstrom's. So 353 patients with Waldenstrom's were evaluated, and about 96 of these patients, so about 27%, so about a quarter of patients, needed to have a dose reduction. More likely, those reductions were due to musculoskeletal symptoms, cardiac problems, rashes, cytopenias, GI symptoms. And it was more common in women and more common in individuals over the age of 65. So most patients went from 420 milligrams to 280 milligrams. And even we have a small group of people, about 25 patients here, who went to a dose of 140 milligrams. So despite the dose reduction, we actually saw that about 2/3 of the patients, actually the symptoms that prompted the dose reduction improved. And so I think that's a good thing, but about 1/3 of the patients, it didn't. Most of the patients with rheumatologic issues and cardiac arrhythmias and GI symptoms actually had improvement. Bleeding, not that much. I think that's the one that responded the least. But all the other manifestations tend to respond at a higher rate. Again, this is in older patients tend to have a higher cumulative incidence of dose reductions. Women tend to have a higher incidence of dose reductions, and they were actually independent of each other. So obviously, if you have a woman who's over 65, the risk is higher than a man who's over 65, and the lower risk of dose reduction is in men younger than 65 in that specific sense. So what we did see is that despite the fact that we stopped decreased the dose, the IgM actually remained really stable, up to 5 years of follow-up in some patients. And actually the max continues reducing in most patients too. So it didn't seem to affect progression-free survival. In this graph, it looks like the patient with dose reductions actually had a better progression-free survival than the patients who didn't. But when we adjusted for other markers and all that, they didn't seem to affect the progression-free survival on these patients. So based on this, it can be done. It seems to be safe. The symptoms seem to improve in these patients. And obviously, I think we need to be aware that women and older patients are more likely to require a dose reduction.
Thank you, sir.
If you want the paper, just send me an email. I'm happy to send you the PDF for your records so you can, study it.
Sure, sir.
Absolutely.
Thank you. We'll use raise hand sign. So if you have any questions, please raise your hand. Meanwhile, may I ask you one question?
Yes.
When the patient relapses, your indications of treatment are identical to a newly diagnosed patient?
Yes, for the most part, right? So if a patient had chemoimmunotherapy as a first-line treatment and is relapsing after that, I tried not to use the chemoimmunotherapy, but I can use protein inhibitors, I can use BTK inhibitors. We didn't talk about this much, but we can use BCL2 inhibitors now in the United States. Venetoclax is actually endorsed by the NCCN for treating patients with Waldenstrom's as well. So if somebody got a BTK inhibitor at the beginning and is progressing a BTK inhibitor, then obviously moving to either chemotherapy or protein inhibitors or BCL2 inhibitors is reasonable. So yeah, I basically, from my perspective, we can use any treatment as long as the patient has not yet been exposed to that treatment.
All right. Questions from anybody else? And the indications remain the same? You must have the same indication as in the newly diagnosed patient, or you?
Yes, that's a great question, because I get a lot of colleagues or patients that come to see me and they was like, yeah, my IgM, started at 5,000. It went down to, let's say 1,000 with treatments. And, 5 years later, it's about to, 2,000 or 3,000. And my doctor wants to start treatment because my IgM is already 3,000. And I'm like, how are you feeling? And the patient's like, I feel great. I'm go to the gym, I run, I did this, I did that. So their blood counts are normal, their activities of the living are normal, and it's just the IgM going up. I do not treat those patients. I still wait until the patient actually meets criteria to treat.
Right. Questions? Yes, Dr. Ranjan.
Dr. Gorge?
Yes.
Yeah. My question is how do you dial up? Do you dial up the dose or come down on the dose? I just wanted to know that. Or do you start with the standard 420, and if it is intolerable, you come down, or an elderly frail patients, you dial up 140 upwards? How do you go about this? I just wanted to know on this part.
Yeah, that's a great question. So obviously, all the clinical trials that we have use a dose of 420 milligrams by mouth, once daily. So that's the standard. So I try, for the most part, to start with the standard dose. The only scenario in which I do lower doses at the beginning is in older individuals. And obviously, the definition of older varies greatly. right? So for my opinion, anybody over 75, I usually start in 280. I do not start at 420. Again, there's no data for that, and I want to be very clear. It's just, I think that it's better in older patients to start a bit lower based on the dose reduction data that we just had. So, and if it's a woman who's over 75, almost always I start at 280 milligrams in those patients. Now, if I have a history of a patient who, who's very small, very thin, a little bit on the older side, sometimes I even start at 140 in a older woman. I usually start at 140 and see how these patients do. And if they're doing well, I take to dial up, but I don't tend to push 420. So I'm really happy with 280 in patients older than 75. And I mean, in our experience, based on this study, they do well.
Yeah, thank you so much, Dr. Gage. I have one more question.
Yes.
Like in our setup, that we are slightly on the lower side of the resources, we generally go with bendamustine rituximab combination over here in India. So, what is your experience in using in the current era with BTK inhibitors? What is your experience of using bendamustine rituximab? Because most of our patients are on BR.
It's a great treatment. I mean, it's a great treatment. I don't want to minimize the efficacy of bendamustine and rituximab. And I think in areas, I mean, I'm coming from South America. I go to South America very often, and there are also some restrictions there. And there, I mean, they use CDR and Bendar only because even Bendar is expensive there compared to cyclophosphamide rituximab. And I was at the workshop talking to my colleagues from Europe, and they also use CDR and Bendar much more than they use BTK inhibitors in the frontline setting. And in most places in Asia and the Middle East, Bendar and CDR are the reasonable treatment options. From my perspective, those are excellent treatment options. And if that is the best approach at the moment because of cost and other issues, I think that's a very reasonable approach too. So I still use it in my clinic too. I talk to my patients. I sit down with them and I'm like, these are the good things about chemotherapy and the bad things about it. And these are the good things about BTK inhibitors and the bad things about it. And then we make a decision together. So before the pandemic, I think for every 5 patients that I talked to, 3 went into BTK inhibitor and 2 went to chemoimmunotherapy. Nowadays, I think it's more 2 to 1, out of 3. So it's a little bit more people are going to BTK inhibitors. But I think it's because of the risk of infections and the fact that patients, who get COVID-19 infection while they're on chemotherapy, they tend to do a little bit more poorly. So I think that's actually has driven some of the patients to actually, in my practice at least, to use less chemoimmunotherapy and more BTK inhibitors. But I use a lot of chemotherapy still in a number of my patients.
One more question, sorry. Which is your first line BTKI in the current era?
That's a great question. So I mean, since the approval of zanubrutinib, I'm using more zanubrutinib than not, but again, if a patient is having toxicity from zanubrutinib, I switch to either acala or ibrutinib. I have done that, and patients tend to do well. But again, I would say since the approval by the FDA in November 2021, I would say 80% of my BTK inhibitor prescriptions have been zanubrutinib.
Thank you so much, Dr. Gage. It was a pleasure.
Thank you. Dr. Vishwadeep.
Good evening. I just wanted a diagnostic perspective. You said lymphoplasmacytic cells are there in the marrow. The patient has hyperviscosity, anemia, IgM is raised. But the CXCR, the mid-88 comes negative by Sanger. So do we need to push more and do other find other specific mutation, or we can just be happy that okay, it's clinically this and wild type
that's a good question. That's a great question. So when patients come to see me with a mid-88 wild type disease, the first thing I try to do is I want to make sure that I'm doing the mid-88 testing correctly. So number 1, from the marrow, right? Number 2, PCR. PCR testing tends to be better than Sanger or NGS even in terms of sensitivity, right? So I want to make sure that I do a PCR from the marrow. That's good. If still negative, right? My recommendation, I mean, obviously at the Dana-Farber, we have other ways to do this. I mean, we do cell selection, we do, whole genome sequencing. I mean, there are other techniques that we can use, but that's not feasible outside of Dana-Farber. So outside of Dana-Farber, what I can tell you is try to differentiate from IgA myeloma. So if there's no kidney disease, if there's no lytic lesions, if there's no hypercalcemia, if there's no cyclin D1 expression, if there's no translocation 11-14, then I think you can safely say that this is not a myeloma, right? So clinical pathological differentiation from, make all the efforts to make sure that this is not IgA myeloma, because obviously the treatment is so different and the outcomes are so different. Clinically speaking, sometimes it's difficult to differentiate from marginal zone lymphoma, right? Somebody has a big spleen, you can suspect that this could be a splenic marginal zone lymphoma instead of Waldenstrom's, for example, with a MYD88 wild type condition. When not sure, but you are sure that it's not myeloma, if you are still not sure if it's marginal zone lymphoma or Waldenstrom's, which happens a lot, I tend to do Benda-R in those patients, right? Because ibrutinib has a much lower response rate to MYD88 wild type disease in Waldenstrom's, have lower response rates in marginal zone lymphoma. So you don't want to risk it. So in those situations in which you don't know, bendamustine or rituximab typically is the answer. If you don't know if it's CLL or Waldenstrom's, which happens in some cases too, because you can have dim CD20 expression in Waldenstrom's, which is not classic, but you can see it, or maybe some CD5 expression in Waldenstrom's, which is rare, but you can see it. Then in those situations, sometimes you can favor the use of a BTK inhibitor. But again, it's more of a clinical pathological, dance to some degree to try to understand, what exactly you're dealing with.
Thank you, Dr.
Hi. Good evening, sir.
Yeah, you have more questions?
So, Dr. Nitin Gupta here from Gangaram Hospital, sir.
Yeah, go ahead, Dr. Nitin.
Yes.
Thank you, Doctor. Thank you, sir, for having Dr. Castillo for this excellent talk. And so my question is, what to do with the patient who have severe peripheral neuropathy? Because I have seen, again, the few patients whose neuropathy continue to progress in spite of them getting a VGPR or PR with bendamustine rituximab therapy. Is it a good option to put them on ibrutinib or genobrutinib if it can help in their neuropathic symptoms?
Yeah, that's neuropathy is the bane of my existence. It's just such a difficult condition to treat. I think we don't know how to treat neuropathy. I don't think we know how to measure the response to neuropathy. We don't know when to treat patients. So there's a lot of things that we don't know about neuropathy. What I would say is the first effort, a good effort, should be placed on understanding how related the neuropathy is to the IgM. I've been surprised myself multiple times in which patients have diabetic neuropathy, in which the patients have neuropathy because of Lyme disease. There are other reasons for the neuropathy, not precisely the IgM. So we need to follow the whole clinical picture, right? As I said before, bilateral, symmetrical, affect the feet before affect the hands, make sure there's no amyloidosis here, make sure, so try to really make sure that you rule out all the other causes of neuropathy before you even start treatment on these patients. If the patients are neuropathy still progressing, despite the fact that you're in a VGPR, there are two potential scenarios. Either the neuropathy is not related to the Waldenstrom's in the first place, and that's why re-evaluating the whole relation between the two conditions is really important. Or the patient has a very, had so severe damage that probably you are getting into a condition in which you are not going to reverse this process because the damage has been so bad. So I reconsider therapy. And I use BTK inhibitors. I use whatever I can do. So anything that can bring down the IgM, is something that I will use. So I have used BTK inhibitors for this. I have used BCL2 inhibitors. I have even used proteasome inhibitors, even though some of them can cause neuropathy. So whatever can bring down the IgM is, the way to treat. But before you get there, you need to convince yourself that is the IgM that is driving this process. Specifically in that situation in which the neuropathy gets worse, even though you're actually inducing a hematological response. And that sometimes is the hardest part.
Thank you, sir. Thank you.
Thank you, Dr. Nitin, for that question. Dr. Nishad.
Sir, I wanted to discuss a case. So this man is a 50-year-old male And for some vague complaints, he was evaluated and found to have a very high total protein. It was 10 point something. And so he was worked up for myeloma. He had a very mild anemia. Hemoglobin was 10. There was no other CRAB features. His immunofixation and electrophoresis showed a IgA lambda band, IgA lambda. And IgA was also elevated. His bone marrow showed around 45% plasma cells, confirmed by 2 pathologists. And so he was labeled as multiple myeloma. However, flow cytometry and immunohistochemistry was not done. He was started on DARA VRD. Post 1 cycle of DARA VRD, again his electrophoresis and immunofixation was repeated, which again showed a IgA lambda band. But after the second cycle, his electrophoresis showed a IgM kappa band. After the second cycle, and then it was repeated after the third cycle. Again, it showed IgM kappa band. He did not have any features of Waldenstrom's. There was no hepatosplenomegaly, no lymphadenopathy, no cryoglobulinemia, nothing. So I am just wondering, sir, what is happening here? Is it a different clone which is now coming up, which is refractory to DARA VRD? Or did I miss, is there any possibility that I miss a Waldenstrom's in the beginning?
Yeah, that's a great question. So just to clarify, you had the appearance of an IgM band, but the IgA band still there.
IgA band completely vanished now.
The IgA
band gone. It's gone.
And the IgA level is normal?
The IgA levels are normal. The IgM twice repeated.
So you could argue that the IgA level is normal and the IgA band is gone because the patient is in a CR from the IgA perspective. All right. Yeah. So I'm going to make that assumption without actually seeing the patient. So we have seen the appearance of small bands, monoclonal bands of other types in patients with myeloma. This has been described actually, in which you have an IgG myeloma, then you can have an IgM band or IgA band, or if you have an IgA, so we have seen this. These bands, in most cases, in the large majority of cases, are temporary, transient, and they resolve spontaneously. So if you are doing the workup and you are, doing another marrow, you don't see lymphoplasmacytic cells, you don't see any symptoms of Waldenstrom's, I'd rather continue monitoring rather than intervening, So just continue monitoring rather than intervening, and I think it's probably the right thing to do. This has been described in Waldenstrom's also happens. I mean, when I'm treating these patients with IgM problems, sometimes these IgG-M spikes do appear. They do last for a few months and then they disappear on the run without any additional problems. So I would think that is probably the case. But again, continued monitoring. And if at some point you see that the IgM is growing to the point that is giving the patients, symptoms or other problems, then obviously you have to do another marrow and make sure that you are not actually dealing with Waldenstrom's. But yeah, it's very possible these are just transient, benign, paraproteins that had no clinical significance.
So, sir, actually, he's post 3 cycles of DARA VRD now, and we repeated his marrow, which shows 1 to 2% plasma cells. His PET scan is normal, and is being taken up for autologous actually.
Yeah, I think that sounds right. So basically, that IgM M spike is nothing that you need to worry about at this time.
Okay, thank you, sir.
Thank you, Dr. Avinash.
Yes, nice talk, sir. I just wanted to know about discontinuing BTK inhibitor. Suppose before surgery, when we stop, so risk of cytokine storm, and if it is there, then how to manage? What do you do when you have to stop it?
Yeah, no, that's a great question too. So we just published a paper. Give me a second here. Specifically providing a table for this, and I'll be happy again to send it over to you, but I want to just show it in the screen really quick. It's not going to take me long until I get it. Let me just quick second. There you go. All right. So this is a paper that we just published that I think you can see it. I hope you can see it. And in this, I mean, this is a kind of a multi, international group of Waldenstrom specialists that we put together our experience, specifically BTK inhibitors. So everything that I mentioned here for Akala and Zanu and, is here as well in this paper too. But this is essentially the duration of holding, ibrutinib or any BTK inhibitor for surgical procedures. So as you can see here for bronchoscopy, colonoscopy, FNAs, core, this is our experience. Again, this is suggested, right? It all depends on who the patient is, what the patient's bleeding risk, if the patient is taking other anticoagulants or other, obviously that needs to be adjusted, right? But this is, what we think is a reasonable recommendation for, holding for surgical procedures. So if you want to take a screenshot or if you want the PDF, please shoot me a quick email. This is open access, so you can actually access this. Actually, Dr. Saroshek's paper, the dose reduction, is also open access. So you just go into the journals and you can actually get these PDFs for your own education. So this is essentially what we do. What I want to say about temporary holding BTK inhibitors is that some patients can develop withdrawal symptoms. And this happens in maybe 1 out of 5 patients. So the patients are doing great. You stop the BTK inhibitor, and within 24 hours, these patients are having fevers, joint pains, night sweats. They feel horrible. So these are patients who develop withdrawal symptoms. And it's very patient specific. So if the patient has a withdrawal symptom when they hold ibrutinib, every time they will have that. And if a patient doesn't have it, they will never have it, even if you hold in the future. So either they have it or they don't. And what we do in patients who have really severe withdrawal symptoms, we think is cytokine release type of syndrome. We do provide some steroids. The patients take steroids on a daily basis during the time that they're holding to minimize the symptoms that they might experience. We tend to use prednisone 10 milligrams twice a day or 20 milligrams once a day to kind of minimize these reactions. And it's amazing. The patient they feel crummy, and then they take ibrutinib within 8 hours, the symptoms disappear. And it's very, very interesting. So yeah, if you want this, there is open access. You can access all these data, at your convenience.
Thank you, sir. Thank you.
Thank you. Dr. Vishnu?
Good evening. So my question is regarding bone disease in Waldenstrom's. So, sir, how do you treat bone disease in Waldenstrom's? Is it like same in multiple myeloma, or treatment strategy is different?
Yeah, so bone lytic lesions are extremely rare in patients with Waldenstrom's. So as I said before, this is actually, it's about 2%, 1 to 2%. This is a paper that just came out from the Danish in a kind of population-based study that they did in Waldenstrom's. So, in patients with lytic lesions, then I treat them as if they had myeloma, right? So, evaluations, and if they need to have radiation for pain or for impending fractures and things like that, bisphosphonates and calcium, vitamin D. But most patients with Waldenstrom's do not have lytic lesions. So in those scenarios, they only, depending on the age and all that, calcium and vitamin D, if they are postmenopausal, have their densitometry scan. So basically treated as a normal individual without other problems, but there's nothing specific that I would do for Waldenstrom's in the patients who do not have lytic lesions.
And sir, how long do you recommend bisphosphonates for these patients?
So that's a great question. I don't think nobody knows. In myeloma is the same. So most of my colleagues in the myeloma group tend to do 2 years of bisphosphonates. So that I tend to do the same thing. Calcium, vitamin D, 2 years of bisphosphonates, and then continue the calcium, vitamin D later on. And obviously you can reassess depending on how the patients do.
Thank you. Thank you.
Thank you, Dr. Vishnu. There's one question lying in the chat box from Dr. Raghavendra. He wants to know whether the dose of ibrutinib or BTKIs can be dose weight adjusted or surface area adjusted.
Yeah, we talked about this earlier, right? So I don't go specifically by body surface area. And actually, we're going to be doing this study. So now that we see about the dose reductions in the women and the age, we're going to start looking at other things, height, weight, BSA. So we're going to do a second analysis to get maybe has to do with BSA or BMI or something of this nature. So we're going to be doing a second analysis on that study that's going to be following. At this time, I don't use the BSA to make that decision. I usually use pretty much the age to make that decision.
Right. Any question from anybody else?
I just had a thought like this. We have TKIs in CML. So like we said, deeper, faster response with second or third, like advanced generations. So was there any difference in the rate of attaining like the response, whatever, like reduction in IgM and the hematological response, and whether you would recommend chemoimmunotherapy versus BTK in patient who has more symptoms if we don't have access to plasmapheresis, and like
Yeah.
what would be the preferred choice?
Yeah, so the time to response between BTK inhibitors, I don't think it's too different. I think in CXCR4 patients, I think Zano might be a little faster than ibrutinib is, but otherwise in the general population, right, I don't think there's any major difference in time to response. Now, if I want to compare BTK inhibitor versus chemoimmunotherapy, BTK inhibitors are faster acting than chemotherapy is. So, you know, if somebody needs a fast response, you know, I know that they will respond faster with a BTK inhibitor, except if they have a CXCR4 mutation, you know, and so that's why in our group it's very important to know these mutation analysis and things like that. I know that outside of these centers it's a little bit difficult to assess that, but yeah, so I think in terms of time to response, I think BTK inhibitors have a little bit of an edge over chemoimmunotherapy in that sense, because not only the IgM goes down, the hemoglobin improves really great. With chemo, you have the IgM going down, but then you have all these cytopenias, and then the patients, you know, patients have anemia throughout, and you know sometimes it doesn't resolve until you complete the chemotherapy. With BTK inhibitors, the hemoglobins improve within 4 weeks, you know, and the patients feel great sometimes within a week of taking the pills, which is an amazing thing. So I think that the time to response is a little faster with BTK inhibitors.
Thank you, Dr. Vishwadeep. I think Dr. Priyanka, you have put a similar question in the chat box, so it's already answered. Yeah. Anybody else has any question? If none, then I thank Dr. George on my behalf, and we have Sumit Kumar to give the official vote of thanks.
Thank you, Dr. Castillo, for sparing your valuable time on this weekend. It was a lucid presentation and different aspects of Waldenstrom with comparative aspects of different BTK inhibitors were touched in your presentation, and we have many key takeaways from this wonderful presentation. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity and making us a part of this elite academic discussion. I also thank all the discussants and participants who have joined us for this webinar. Last but not the least, this webinar would not have been possible without relentless support from Perfect Square team. Thank you so much, everybody, and have a lovely weekend.
Thank you very much for the kind invitation, Dr. Agarwal. Thank you, Dr. Madan, for your invitation. Everybody here, it's really a pleasure to be able to reach you for so far away in the world. And again, I remain available for any additional questions you may have.
Thank you. Thank you so much. And have a wonderful day, Dr. Castillo.
Everybody have a good night.
Bye-bye.
Good night.